So today I'm presenting a systematic review that I had published in the run-up to starting my PhD last year in the International Breastfeeding Journal. And it's all about looking at the barrier that medication can present to breastfeeding. So hopefully my slides are moving on. So I normally start with going through the benefits of breastfeeding and why it's really important, but I don't think any of you need to know that. And I'll just touch briefly on the difficulties around medicines, just in case that's not your sort of areas, but I'm sure you probably know anyway. So medicines can pass into breast milk and affect the baby, depending on the nature of the medication and sort of how well the baby can process that medicine. What's more, breastfeeding women are usually excluded from the clinical trial phases of drug development. So as a result, most medicines don't have a formal license for use in breastfeeding. And that's why you'll see packets of medicines saying things like, do not use during breastfeeding. But in reality, most medicines are likely safe. And we know this based on pharmacokinetic data. So that's the way the drug behaves in the body and from post-marketing studies. There are brilliant resources available that summarize this evidence, and medicines shouldn't be seen as a barrier to breastfeeding. But I wanted to know by carrying out a systematic review, how often are mums stopping breastfeeding because of a medicine? What medicines are implicated? Who or what is influencing these decisions? And are there any particular groups of women who are more at risk of stopping breastfeeding because of a medicine when they don't actually need to? So I searched through 6 relevant databases and conducted forward and backward citation searches. I included any studies that were conducted in the last 20 years because I wanted to have sort of a broad range, because I didn't expect lots of results, but I put that 20-year cutoff in because that kind of coincides with when the internet became sort of widely adopted, and I just felt before then the world would have been a different place and the way we communicate information would have been a different place. We only included high income countries, that we were comparing apples with apples. We only wanted to know about women who were self-reporting breastfeeding discontinuations, so not studies that were sort of second-hand accounts from healthcare professionals or assumptions based on trends, for example. We included studies that involved combination feeding and the sort of administration of expressed breast milk, but we didn't include any studies involving donor milk. Exclusion criteria are listed there. We didn't include any studies involving HIV, women with HIV, just because that would be a confounding factor. We weren't interested in alternative or illicit medicine use. And we only looked at women who started breastfeeding but then stopped, rather than women who never started breastfeeding at all because of medicines, just for simplicity more than anything. So I extracted a variety of data and completed a narrative synthesis. We wanted to do a meta-analysis, but there was just too much heterogeneity in our results, so we couldn't do that. So I grouped the results by outcome and presented them in tables in the paper. And the implicated medicines I classified using Hale's lactation risk categories, which I'm sure you're probably familiar with. Is one of the reference sources that sort of tell you about the safety of medicines in breastfeeding. We did some quality assessments on the papers included. So we used a modified Newcastle-Ottawa scale for cohort and cross-sectional studies, a JADAD scale for, there was one randomized controlled trial. We had 20% of the quality assessments second checked, and we didn't exclude anything based on quality. We sort of kept everything in there. So that was the Prisma flow diagram I ended up with. So we had After removing duplicates, just under 5,000 papers to sift through. And then after a title abstract screen, we were left with just under 300 to do a full text screen on. And then after citation searching, we ended up with 20 papers in the final study. So the results. So starting with in women who need a medicine, how many of those are stopping breastfeeding because of that medicine? So we divided up the papers that we had into two. So there was some that were looking just at general populations of women, and then some that were looking at sort of specific populations of women with specific chronic conditions. So in general populations of women, discontinuation rates ranged between 2 and 18% of those who needed medicines. If you look at those with chronic conditions, that rises to up to 58% are stopping breastfeeding because of a medicine. This large range is likely due to quite a lot of heterogeneity in study design, medication type, follow-up period. So just as an example, the 2% figure came from an Italian cohort study, but they only followed women up for 4 weeks, whereas the 58% figure came from a Dutch cohort study, and they followed right up until 6 months. So it would have been interesting to see what the Italian study found at 6 months as well. So then moving on to what medicines were stopping women from breastfeeding. There were 15 studies that had data on this. By far the most studied class of drugs was DMARDs, which is disease-modifying anti-rheumatic drugs, which are used to treat things like rheumatoid arthritis and lupus. Statins and drugs for multiple sclerosis were also quite well studied as well. So the two graphs summarize the number of cases of medication-related breastfeeding discontinuation reported by drug class. I think the most striking thing for me that there's an awful lot of drug classes that haven't been reported on at all that you would expect women of childbearing age to be using. So things like diabetes, respiratory conditions, hypothyroidism, epilepsy, inflammatory bowel disease. And then this graph just summarizes the implicated drugs by Hale's lactation risk categories. So you can see that the vast majority of drugs are at least L3, which means at the very least presumed compatible. So there was only 2 cases that involved something that was potentially hazardous, and that was lithium. And then moving on to the third objective, which was looking at what was influencing women in making these decisions. We found 6 papers that spoke about healthcare professional advice sort of being an influencing factor. So healthcare professionals were found to be advising women to stop, and therefore women taking that advice. And this was coming from a whole range of healthcare professionals: midwives, health visitors, GPs, paediatricians, other physicians. Interestingly, not pharmacists, but I suspect pharmacists are a problem as well. And there was one paper that I found interesting where they had 5 women who were advised to pump and dump. And in all 5 of those cases, it led to unintentional discontinuation because of reduction in milk supply. There were a couple of papers that spoke about a positive influence of healthcare professionals, so lactation consultants and targeted educational programs. Looking at sort of personal concerns from the women themselves and not coming from healthcare professionals, there was very limited in-depth assessment of this and where it came from. The only sort of really interesting one was a qualitative study looking at women on opioid substitution therapy, which spoke about skepticism and concerns about medication exposure, beliefs about the impact of breastfeeding on infant withdrawal, which is quite a specific circumstance. And they also spoke about feeling like they didn't have control over decisions, and they were being told what to do by healthcare professionals. And then finally, just looking if there are any risk factors for women making these decisions. There was a good study in Greece that found some statistically significant risk factors for stopping breastfeeding because of a medication. And that includes lower educational level, which you would probably imagine, cesarean birth, medication for chronic condition, which again sort of reflects what we found earlier on, going back to work at 6 months postpartum, having less breastfeeding experience, and also smoking pre-pregnancy. Maternal age, nationality, parity, and employment status didn't have any association. And then there was just one other study in Israel that found that the more medicines you were already on, the higher chance you would stop breastfeeding if you add in another medication. So that was the results. So that's just a summary basically of the headlines. So yeah, medication is leading to breastfeeding discontinuation. In general populations, it's 2 to 18%, but rises to up to 58% in those with chronic conditions. Most implicated drugs are likely safe, and healthcare professional advice is playing a role. Looking at certainty of evidence, so with the grade criteria, it's very low. There was a lot of methodological weaknesses, inconsistencies, and lack of generalizability, with a lot of the studies reporting an overrepresentation of white, highly educated women. There have been a couple of earlier similar reviews which found similar issues with overly cautious advice from healthcare professionals, a lack of generalizability, and outdated evidence. So a lot of the studies that other reviews included were from the early 90s, which it was a long time ago now. So it's clear that a lot of research is needed in this area. So examples of gaps is sort of really in-depth qualitative work on women's perspectives and how they make sense of all of this. The use of theoretical frameworks to map those influencing factors on their decisions. Oh, I pressed a button. Let's go back. The inclusion of broader populations and sort of other postpartum medications that you would expect to see in women. And future research does need to ensure more diversity and equity in sampling. So this brings me nicely onto the PhD study that I have planned, that I'm about 4 months into now. So there's going to be three phases to it. So we're going to start by surveying 300 women who we're going to recruit just before they have their baby and follow them up periodically until 9 months postpartum to have a look at what decisions they're making if or when they're presented with a need for medicines, what is influencing those decisions, and also if there's any groups who are more at risk of stopping medicines, stopping breastfeeding unnecessarily. We're then going to interview a sample of 20 of those women to kind of dig deeper into what's going on. And then finally in phase 3, we're going to use everything we've learned to co-design some kind of intervention with women and appropriate healthcare professionals as well. And that's it. I just acknowledge my funders and my brilliant supervisors, and please feel free to get in touch with me if you have any questions after this.